The Becker's team is excited to be making our return to in-person events this fall. Join us in September for Becker's Hospital Review 6th Annual Health IT and Revenue Cycle Conference. We have opportunities to attend the in-person program in Chicago and also to join us virtually from the comfort of your own home. For information about registering and to find out if you are eligible to attend free of charge, reach out to us at registration@beckershealthcare.com.
This is Scott Becker with the Becker's Healthcare Podcast. Thrilled today to be joined by David Sylvan. David's the president of University Hospitals Ventures, and he's sort of had this fascinating career and a brilliant person. We'll talk to David today about what he's most excited about this year, where the priorities are, how he's seeing competition and strategy evolving, and a little bit more. David, take a moment and both introduce yourself and tell us what are the big priorities. What are you most focused on this year?
Yeah, hey, Scott. First of all, really good to be back in contact with you. You know, when I think about the things that are sort of most exciting to me, we're going to go back to the future. We are in the middle of hoping to pilot something called UH at Home, University Hospitals at Home. But Scott, not in the traditional physician house call with a funny looking bag, stethoscope around the neck, and that you probably recall this, that damn wooden tongue depressor that always made us gag when we were kids. This will really be in-home, in-person interactions facilitated through our home care and our APP machinery. It'll include daily RN and physician visits, things like medication and oxygen administration and monitoring respiratory care. It'll include things like mobile lab services and radiology. But I think what's most exciting for us, Scott, is that this will eventually be, the decisioning will be aided by technology. Some will be powered by traditional wearables and monitors, and some will be powered passively via ambient in-home sensors, if you will. And add to this a little bit of self-reporting and patient engagement, but we're all working in tandem to allow far more folks to stay in the safety of their homes, but with the eagle eye support of the platform being monitored 24/7 by RNs. And, you know, the things that we're looking to prove out are impacts on things like length of stay, readmissions. Obviously, always want to impact those ED frequent flyers, Scott, comorbidities, and also purely experience, both the patient and, of course, we can't ignore the care team, their experiences. So how will all of this impact outcomes broadly defined? So that's something that we're working on that we're pretty excited about.
And take a moment there on the hospital at home or more home care at a deeper level, not Marcus Welby, but so forth. But what about the concept of, like, will it be through an iPad, a display, or will a nurse come visit, or some mix of both? What does that look like?
Yeah, obviously we're at a point where we can't ignore the physical interaction, the in-person interaction. So it actually starts with the discharge, usually from an inpatient setting or from the emergency department. It starts with the patient being transported safely to their home by paramedics. And then once at the home, the patient being evaluated by that trained transport team and a provider who conduct that initial visit in order to make the assessments. Then the interactions become daily visits by a physician or an RN, either in person or by video conference, depending on acuity, depending on need, depending on need to react. There will be 2 daily in-person visits to monitor progress with regard to meds and oxygen delivery and monitoring. You know, the notions of labs and physical and occupational and speech therapy, all of those will be delivered in the home. And then, of course, there's that digital tethering. You know, we will use a variety of devices that, you know, will pick up things like pulse ox and you know, temperature, etc. Might not necessarily need to be, you know, borne on the patient full time, depending on the disease state or the condition. And then finally, a thing that we find to be critical is we're also going to be curating the patient's meals based on specific needs, diabetic meals, low salt meals, etc. So it's an attempt to be pretty holistic and to avoid all of those extra days, inpatient days that are usually the case for patients, that would fall within these types of parameters.
And how important is it the patient has a support network at home to take advantage of this type of care model, or can it be done regardless? Because you have many older people that live alone, many that don't, and obviously many younger people that live alone and many that don't. How dependent is it that you have some help in the family or that you buy some support, which can be expensive and sometimes not covered?
Yeah, absolutely. And certainly we're cognizant of the reality that there's never a one size fits all. But to the extent that there's less capable assistance at home, we would need to then titrate up the extent to which we have, either digital or in-person intervention and interactions. Obviously, at a certain point, if the person's, either from an age perspective or their ability to impact their own needs perspective, this might not work for them specifically. But for a relatively material subset of the population, we think this could make a difference. Again, not a one size fits all, Scott.
So you just hit the sort of you just hit one of the most important points of this is you said a material portion of the population, and how do you start to think about that and measure it? Is it 30% of the people that would have typically got hospital visits for a medical type of condition might be doing this at home? Is it 60% of recovery? You could shorten the length of stay more than we ever were able to because we're doing more recovery at home. Is there any sense yet of calibrating those numbers, David, and getting a sense of that?
So we're beginning that. We're doing the proof of concept right now. We're not even sort of a full-blown pilot. But right now we do look to certain demographic parameters in order to delineate who might be eligible. We want patients who are 17 years or older. We want patients who have the ability to be transported to home between 7 a.m. and 7 p.m. So there needs to be both the environment, the condition, in-home conditions to enable that to happen. There are other admission criteria. We have a utilization management protocol that we're looking to put into place. All the screenings related to things like COVID-19 and other conditions, comorbidities, COPD, cellulitis. Those are sort of some of the high target areas that we know we can impact. We do, at this point, want the patient to be covered under a traditional Medicare insurance plan. And the patient must also be able to wear monitoring devices and use technologies and have access to required communication tools. Usually the bar there is a smartphone. So again, we're starting with a demographic or a persona, if you will, that will enable us to win in the early days of the proof points for this program. And then those learnings will begin to inform how we can, land and expand, how we can increase to perhaps some of the more at-risk population. Don't have definitive answers yet in terms of what type of velocity we'll attain and, what the denominator for that will be. But it's not just merely based on intuition, Scott. We certainly know that there are a material, again, I use the term without defining, but a material percentage of patients who stay inpatient longer than they possibly would need to be.
Certainly, in a fascinating perspective. Got it. And so one of the things you're most excited about is the evolution of this hospital at home concept, which is a different acuity level, a different way of bending the cost curve, a different way of improving care so patients could be at their own homes, and magnificent, a different level of what used to be home health care, but really a whole different acuity level and so forth. Talk about what else, when you look at, you've got this fascinating role in University Hospital Ventures, president of that organization, and that role, that leadership. What else, David, are you particularly excited about this year? What else comes to you top of mind? Think like, I'm excited about that. We're working on this, or we're doing this, or we see this future.
Sure. Well, I'll tell you, one of the pandemic's consequences, Scott, intended or otherwise, was was really to sort of initiate this digital tools arms race for many systems. And, you and I have talked about this in previous conversations about the genie not going back into the bottle when it comes to things like telehealth or remote patient monitoring. And of course, both have spawned the UH at home that I just talked about. But as a result, you're seeing substantial deployments of resources, both people and capital, towards digital point of care solutions. And you talk about the things that excite me, this notion of digital tethering that I've talked about before and monitoring, but taking these a step further. So not just tools to enable the conveyance of data and information, but also the engine, the AI and the like to guide decisions and interventions. And I'll tell you that in my mind, the systems who can't or won't or don't look to aggressively lean into the integration of this tool set into their care delivery models, they're going to be forced to continue to rely, maybe even disproportionately rely, on in-person encounters and their physical plant strategies just to stay viable and profitable. This will just be exacerbated as we continue down that volume to value path, and you're going to see net margins continue to erode. I'm not implying, Scott, that we'll transition to a predominantly digital mode for patient interaction, but what excites me is that this tool set, if used and deployed appropriately, could have a meaningful access, and again, I use the word experience impact. And of course, the latter affects, not just the patients and families, but the providers as well.
Just magnificent, David. And when you look at healthcare today, University Hospitals, great franchise, great system, great mix of academics, community service. Where do you see strategy and competition evolving? Is it competition against outsiders, CVS, Aetna's, the Optums, the Walmarts? Is it competition against the telehealth that want to be primaries at Medicare managed care plans run by big physician groups? Where do you see competition evolving that you think about, or don't you spend a lot of time thinking about it? What's some of your thoughts on it?
Yeah, we always have an eye on competition. And the ironic answer from my perspective is the competition that we face through consumers, patients having choice. It used to be that regardless of the experience that I delivered to you, Scott, as the patient, you didn't have a choice. And so what it felt like and looked like as you try to access our system and get that appointment and then navigate your way to us both, either electronically or physically once you got to our system, and the what happened to you in the waiting room and the 9 times we asked you for the same information. There are ways for you to begin to avoid that. And so if we don't think about a head-to-toe reassessment of how we deliver care, how we deliver health, and how we deliver wellness to our patients, the competition will come from all forms. They're going to come from those platforms that can deliver those virtual visits in a seamless way. Those platforms who cut through all of the process associated with registration. And then, of course, the back end, those systems that have solved for, on a revenue cycle management perspective, the nightmare that is still billing, and the way in which you have to try to decipher on your own without any cheat sheet what you're paying for, what something cost, what you're being reimbursed for from an insurance perspective. I was once told by the president of our system, Dr. Dan Simon, close your eyes, spin around, throw a dart. Whatever you hit in healthcare probably needs to be fixed in some way. So I think that's what we all have to be very vigilant about when it comes to the various roles we play within these provider systems.
Well, let me ask you a question.
Sure, please. Yeah.
But what you just said was fascinating. I mean, this concept of close your eyes, throw a dart, and something's got to be fixed. Whatever you hit's got to be fixed. And this is a complicated issue, because when you look at a country of 330 million people, I don't disagree with Dan Simon, but for a country of 330 million people, there are gaps, but a lot also goes right. from my perspective, we're the largest country in the world where a lot of things go right in healthcare. And there's not very many countries that have as much size as we have. When you get past us, there's China and India, and I think a lot of things go right in this country comparatively, but there's a lot that needs to be fixed. How do you prioritize what needs to be fixed? How do you decide, like, so much does need to be fixed that it's almost like, and the world moves so fast today, that could be very bewildering. But how do you decide what needs to be fixed? Where do you put the priorities and the energies?
Well, I think you have to look at those issues that have the greatest potential impact or value contribution. I totally agree with your assessment that there's far more that's right than wrong. And the things that are wrong in many respects are things at the margin, but things that are still either frustrating or vexing. I don't think we should stop striving for perfection, though, even though so much is right and so much is far better on a comparative basis. But if we want to look towards zero harm and zero defects, it does take relentless attention being paid to all of these issues that, seen on a one-off basis might not appear to be too material, but when you stack them back to back, they become part of this continuum that sort of slows down the pace with which we either deliver care or we move the business of healthcare forward.
No, and I think that's right. It's really trying to assess what will have serious impact if you fix it or improve upon it versus things at the margins that, of course, could use fixing too, but the mental energy and the people and the focus aren't worth spending there, or they're not worth spending there right now.
Right.
David, it's always brilliant to visit with you. It's one of my favorite opportunities to get a chance to speak to somebody. Just literally always learn something, always interesting. I love this phrase that if you turn around with a blindfold and throw a dart, you'll find something that needs fixing. And I couldn't agree more, yet I put it in the context of what a great system we have on so many levels. And then it becomes an issue. Where do you prioritize trying to improve things and fix them? David Sylvan, a pleasure to visit with you. Thank you very much for joining the Becker's Healthcare Podcast again.
Pleasure was mine, Scott. You take care. Thank you very much.